Good afternoon, everyone, and welcome to today's webinar, Supporting Dementia at Home. I'm Cheryl Mayerick with the Atlanta Regional Commission, and I will serve as your technical producer today. We are pleased you're able to join us for this special Empowerline event, which is part of ARC's ongoing webinar series. Let's cover a few housekeeping items before I turn things over to today's moderators. Here's a screenshot of the attendee control panel. You should see something like this on your own desktop in the upper right-hand corner. Throughout the webinar, you will have the opportunity to submit text questions to organizers and to chat with the group at any time by using the gray tabs in the control panel. We will address the questions as time allows after our first speaker and again after our panel discussion. Note that you are in listen-only mode. If you happen to click away to another application or browser, you can find us again by looking for the little blue flower petal icon, generally in your ribbon bar at the bottom or the side of your screen, or you can look at your other open browser tabs. The orange-colored arrow on the control panel for this software will collapse and open the control panel. And if you move it to another part of the screen, if you desire. Today's meeting will be recorded and will be available in a follow-up email in the next 24 to 48 hours, and it will be posted on ARC's webinar page on our website. I'll now turn things over to today's moderators, and Sue, if you want to take it away. Sue, I think you're muted.
So sorry, everyone. Thank you, Cheryl. Welcome, everyone. We so wish we could be in a large room with everyone, but that's not going to be possible in this environment currently. So we're really pleased to see so many attendees at this forum, Facing Dementia Together, Dementia at Home. My name's Sue Burgess. I'm the Assistant Director of the Area Agency on Aging for the Atlanta region, consisting of the 10 metro counties. We're housed within the Atlanta Regional Commission, and our mission is to ensure that older adults and persons with disabilities live meaningful and healthy lives in their community. Without further ado, we have a very esteemed panel. I'd like to move it over to my co-moderator, Kara Polino, who is the Access to Services Unit Manager in the Aging and Independence Services Unit within the Atlanta Regional Commission. And over to you, Kara, and we'll begin the program. Thank you.
Thank you. Thanks, Sue. Before we get started today, we really are interested to know who is in our audience. So, Cheryl, can you please open the poll?
I sure will. And the question is, to get an idea of who is in the audience today, we're asking you to self-select if you are a family or individual with lived experience, if you're a provider of services, if you're a professional or other. And at this point, we have 48% of you voting. We're going to wait just a few more seconds. Wow, we have 75% of you voting. Let's give it 5 more seconds. And I'm going to go ahead and close the poll and share the results with Kara.
Excellent. Thanks, Cheryl. So this is great. We can see we have a good portion of people who are living with dementia. They are representing people with lived experience. We have a good portion of people who are providers of a service to those individuals, professionals, and then some other people. So we're really happy that all of you can join us today. We have such an incredible program today, and we have amazing speakers. So I don't want to spend too much time talking myself or even going into bios. Everything will be posted, including the bios, and we'll put that slide up at the end of our presentation. But I really wanted to jump into the first part of our program. I am so excited to introduce Dr. Jim Law. Dr. Law serves as the Associate Director and Clinical Core Leader of Emory's Alzheimer's Disease Research Center. He leads numerous research efforts devoted to improving the evaluation and care of patients and families living with dementia. He's going to provide us today with an overview of what he's been doing, and without further ado, I'll pass it off to Dr. Law.
Dr. Law, you may be self-muted.
Can you hear me now?
We can, thank you.
All right, I'm just seeing the quick poll results on my screen still, I think.
All right, well, let's see if we can get rid of those for you.
And if you would give me the option for sharing, I can go ahead and put my slides up.
It is already shared with you.
Oh. Okay.
Okay.
So I'm not
All
getting the option to show my screen.
All right, let me try this one more time. And you should be
There we
able
go.
to. Okay, great.
Got it. All right, well, sorry about that. I hope you're seeing my screen now. Is that showing properly?
We are struggling just a bit. If you would continue on, we'll do our best to get this fixed.
Okay. How's that?
I don't have it. I don't know what I've done. But I'm not seeing that screen. I'm still seeing the poll that we did.
Okay, bear with me for just a second. Okay, nope, we're not having luck with this. Hold on just a minute. I apologize to everyone. I can't seem to close the poll. Dr. Law, if you could maybe just start on your presentation and I will work to catch us up on your slides.
I will do that. It's always a little eerie doing these webinars when I can't see the audience. But what I hope to do today is to give everybody a quick review, very brief review. We won't go into a lot of detail in any particular area, but I want to just give everybody a quick overview of where things are and some of the hopeful things that are on the horizon, as well as some challenges that continue to plague us. And right from the beginning, I want to answer a question that I think we've gotten at virtually every single presentation that I've given in the community, and that is somebody wants to know what is the difference between Alzheimer's and dementia. And since we're talking about dementia, and we're inevitably going to be talking about Alzheimer's disease, this is an important distinction for us to all understand. And the example that I've chosen to try and illustrate this in my slide is to say that saying that somebody has dementia is kind of like saying somebody has a headache or my head hurts, and that's a description of a symptom that doesn't really tell you what the underlying cause for that symptom is. So a person may be experiencing a headache because they have an aneurysm that's underlying that's about to rupture, and they're having horrible headaches as a consequence. Or your head might hurt because you're Tiger Woods and you're an idiot and your wife took a 7-iron upside your head. Either way, your head's going to hurt, but the underlying cause for the headache is quite different. And so when we talk about dementia, we're really talking about symptoms. And I think most everybody on this webinar understands that it's a set of symptoms that can be quite devastating. Often in the beginning, symptoms may be very, very mild, but over time, as the disease progresses, whatever disease is causing the dementia symptoms, the impairments can become quite severe and the functional limitations can be quite severe. And we talk about Alzheimer's disease all the time because it is, among older adults, the most common reason why individuals may be experiencing dementia symptoms. And I see Sue. Sue, should I try and share the screen again?
Yes, we're seeing the screen now, Dr.
Oh, you are. Okay, great. So let me
expand it. That would be ideal if you could expand it. Thank you.
Excellent.
There.
There we are. Okay. So you're seeing the presentation mode and everything else?
Yes, it was here. It just went blank, unfortunately.
Oh, you can't see it now?
Back on it now. Yes.
All right. Well, we can just work through it.
The slide is what's the difference between Alzheimer's and dementia.
Okay.
Yes.
Let me try and do this. I'll do a different share. I'll just share my entire Finder, and you tell me now if it's showing properly.
No, I'm seeing like a very small list here.
That's
there,
perfect.
yeah. Perfect.
Okay. Is it showing in presentation mode? Do you see it well?
Presentation mode, perfect.
Outstanding. Okay, so let me try and make up for a little bit of lost time. So we talk about Alzheimer's disease because it is the most common disease that causes dementia symptoms in older adults, but it's certainly not the only one. There are many other conditions, including Lewy body dementias and vascular dementias, frontotemporal dementias, and many less common conditions that can also cause progressive cognitive loss and dementia. And it's also important to realize that although we talk about Alzheimer's disease as though it's a single entity, in fact, the disease itself can be highly variable. And when we look in an autopsy series, the underlying pathology of Alzheimer's disease may be combined with Lewy bodies or vascular changes. Both of those shared pathologies are extremely common. But nevertheless, there are distinct underlying diseases that cause dementia symptoms. And because Alzheimer's disease is such a common and important one, I want to spend just a couple of minutes talking about some of the background. This is a famous photograph of Frau Auguste Dieter, who was the first patient that Alois Alzheimer's studied with this condition that came to bear his name. And when she was admitted to the hospital, she was very young. She was only 51 years old. And in retrospect, it turns out that she had one of these extremely rare diseases that causes early onset Alzheimer's disease. But in other respects, she was similar to more typical patients with Alzheimer's disease experiencing progressive memory and cognitive decline. She experienced some delusions of persecution and infidelity on the part of her husband, and eventually died at the age of 55. And then this fellow got a chance to evaluate and examine her brain after her death. And there were two key changes in the brain that are pointed to by the arrows here. The first being these amyloid plaques, this big blob in the center, and these amyloid or senile plaques in combination with these darker structures, which are called neurofibrillary tangles made up of this protein called tau, are the hallmark pathologies of this disease. And you'll see this picture again because those pathologies have started to play an important role in understanding and diagnosing and treating Alzheimer's disease. And more recently, in the 1990s, for a number of reasons, this amyloid cascade hypothesis came to dominate the field of Alzheimer's biology. And the hypothesis suggests that that the accumulation, the abnormal accumulation of these amyloid plaques inside the brain is responsible for triggering the whole series of events that eventually leads to cognitive decline and dementia that we associate with Alzheimer's disease. And an important corollary to that is that if we can find a way to prevent or remove these amyloid plaques, perhaps that will have a significant beneficial effect in terms of treating the disease of Alzheimer's disease. The effect of Alzheimer's and related dementing illnesses is a global one. It is a pandemic that really is unsustainable on a global scale. In 2018, it exceeded $1 trillion in overall costs for patients with Alzheimer's and other dementing illnesses around the world. And you can see the projected increase through the middle of this century. And what is perhaps even more disturbing is that the projected increase will hit particularly hard in those countries that are least well equipped to manage this kind of a crisis. So this is a global epidemic that is a slower burn than the horrible pandemic that we're all experiencing now, but ultimately it is a crisis that must be addressed just as urgently as the COVID-19 pandemic. It's a national crisis, certainly. In the United States, we estimate that about 1 in 10 adults over the age of 65 has Alzheimer's disease, and it's a Georgia crisis. This map shows the projected change in Alzheimer's disease rates in different states, and the deeper purple colors represent those states that are expected to have the highest proportional increases between 2016 and 2025. And so you see that Georgia is predicted to have about a 35.7% increase in that time frame. So this is a crisis that affects the state, the nation, and the world at large. And so we all need to tackle this very seriously and aggressively. So let me just get right to the punchline and tell you what how I view the cure for Alzheimer's disease that I have been saying that I expect to see for over 20 years now. Since I was a much younger man, I've been promising my patients and their children that before the end of my career, I expect to see an effective cure for Alzheimer's disease, and I still believe that. This graph just gives a pictorial depiction of the decline over time with Alzheimer's and with other dementing illnesses, but there is this long period of time where there are no symptoms, and then very early stage symptoms with something called mild cognitive impairment, where there may be just isolated memory deficits, but independent functioning and really a normal quality of life. And then with progressive worsening, there may be some functional limitations associated with mild dementia. And then as the disease becomes more severe with moderate and severe dementias, there is where we find the more profound loss of abilities and the deterioration in quality of life. This is the picture that people most often have in their minds when they hear Alzheimer's. And it's a terrifying prospect, but it's important to understand that this is really the end stage of Alzheimer's disease. And so people who are experiencing very early stage symptoms can still be experiencing an excellent quality of life. And so for me, the cure for Alzheimer's disease is not an anticipation that we'll be able to take somebody who's in these terminal stages and reverse them back to a state of being normal or less severely affected. The cure comes in the form of disease-modifying therapies that will slow the development or slow the decline associated with disease, because I think we all, at some level, hopefully recognize that none of us is going to get out of this thing alive. And so the goal for me and the cure for Alzheimer's disease, in my mind, is that when you get run over by that bus, you're still functioning at a high enough level that you're enjoying good quality of life, enjoying your family and friends and loved ones, and are still having a good quality of life. And if you drop dead of a heart attack, you know, the cardiologist loses, the neurologist wins, and everybody goes home happy. So this is what I expect to see, and I'll tell you a little bit more about how I think we're going to get there. For many years now, we have been able to diagnose definitively the presence of Alzheimer's disease in living people. There was a time when we said that you could only be certain of it if you were able to examine the brain after death. In fact, we routinely now do diagnostic tests, and this is actually my butt sticking up right here, you know, in pants, but my butt, while my friend is doing a spinal tap on me as part of a research protocol. And we do this spinal fluid collection as part of research and as part of clinical diagnostics, because we can evaluate these proteins, the amyloid protein and the tau protein that are associated with those plaques and tangles, and make a definitive diagnosis of the presence or absence of Alzheimer's pathology in the human brain. Something that's a little bit easier to recognize, and those are the plaques and tangles from that picture that I showed you earlier. Something that's a little bit easier to understand is when we look at tools that allow us to visualize the pathology. So this is a special tracer that gets injected into the bloodstream, and this is a tracer that goes into the brain and will bind to areas where the tau protein, that tangle protein, is present. And these are different individuals with different amounts of the tangle pathology, and you can see the bright colors, the brighter colors that represent the places in the brain where the tau pathology is present, and this dye has gone in and bound, and we can see this in living people. And likewise, the amyloid pathology is visible when we do these special scans after injecting an amyloid dye. And these individuals who have Alzheimer's disease will have evidence of lots of this amyloid pathology, while those who are normal without evidence of amyloid pathology will show no signal. However, one important caveat is that this image here is also from a normal person, a person without any memory, any dementia or memory symptoms, and yet they clearly have a lot of amyloid pathology that in many cases may be comparable to what you see in somebody who actually has Alzheimer's disease. And so this is an important piece of information that's accumulated over the past 10 to 15 years that has come to change our view of Alzheimer's disease as much more of a more typical chronic disease. So when we think about chronic diseases, we think about heart disease, cancer, things like that. And when somebody has, when Fred Sanford had the big one, he didn't all of a sudden start building the blockages in his coronary artery. It built up over a period of many years and decades. And Alzheimer's disease is the same way, and we should be approaching it in the same way. We don't wait until somebody has a massive heart attack to try and treat their heart disease. Actually, one of my colleagues corrected me the other day because I said when you turn 50, you get a couple of things. You get a birthday present, and then you also get an invitation to get a colonoscopy. And she told me that the age has recently, recommendation has changed to about 40. But you know, the reason you do those things, colonoscopies, calcium scans for your heart, is because if you identify the presence of those pathologies early and intervene, you can avoid the bad outcomes associated with those chronic conditions. And the way that we understand Alzheimer's disease now is that the pathologies, the amyloid pathologies, the tangle pathologies, those things are present in the brain and evolving, we think, for 15 to 20 years before individuals start to develop memory loss and dementia symptoms. So this green line represents worsening dementia symptoms. And these pathologies, we think, are evolving for 15 to 20 years before any clinical symptoms manifest. So this is a very different way of thinking about the disease, and tells us, as in all chronic diseases, the approach to take is not to try and fix disease, but to try and prevent disease. And that ultimately is where we need to go. The amyloid cascade hypothesis that I mentioned has dominated the therapeutic development. And so there are a lot of treatments that have been tested to try and remove the amyloid protein. And in fact, we have had methods that have been successful in removing the amyloid pathology from human brains for going on 20 years now. They weren't successful in most cases. For different reasons that we don't fully understand. We think part of it was the timing. But these are some results from a treatment study that was published a few years ago. And what you're seeing here are pictures of an amyloid PET scan with the red areas indicating areas of a lot of amyloid binding. And these are 3 different individuals at baseline, so when they were entered into this clinical trial. And after 1 year, individuals who were on placebo or and not getting the anti-amyloid drug, their pathology looked quite similar. But individuals who got increasing doses of this antibody against the amyloid pathology had significant and dose-dependent removal of the amyloid. This is something that is not unique. What was unique in this study is that they also saw evidence that with increasing doses of the drug, with higher doses of the drug, the amount of decline that these individuals experienced, this is the amount of decline for those people who were on placebo after 1 year, and with gradually higher doses of the drug, you saw less and less cognitive decline over the span of 54 weeks. So a true disease modifying effect. This was an early study and it was inadequate to demonstrate clinical effectiveness. However, these were the results from 2 larger phase 3 trials. These are the last stage trials. You've been hearing a lot about vaccine trials going into phase 3. This is when you test whether or not the drug or treatment proves to be effective and beneficial. These plots on the left just show the amount of decline or elimination of the amyloid pathology based on those PET scans that I was showing you. And really after a year and a half of treatment with the highest dose, the amyloid pathology signal is essentially undetectable, no different from control individuals. More importantly, over the course of the study period, and this is now data out to over 72 weeks, the individuals who are treated with the highest dose of this aducanumab drug, 10 milligrams per kilogram, actually start to have slowing of their cognitive decline that appears to be flattening out. This was sufficiently convincing, and it was statistically significant that the drug is now before the FDA requesting approval for regular clinical use. So we have to really think about what are we going to do if aducanumab becomes approved? Who's going to be eligible for the drug? How will the drug be delivered? It's an IV infusion. It's going to be extremely expensive and will only be able to be administered through infusion centers. And so how will people access that? And we should also ask ourselves, how prepared are we for the advent of these kinds of drug therapeutics? Many people who have Alzheimer's disease or dementing illnesses never get a specific diagnosis, never. And often the diagnosis is delayed by many years. And this drug, the aducanumab drug, and newer drugs that are being developed right now, the earliest ones are only going to be effective in people if we treat people in the very earliest stages of their disease. So early recognition and accurate diagnosis becomes extremely important as these treatments are developed. And then in the meantime, there is this ongoing extreme need for ongoing care and support to optimally manage our patients who already are beyond the point that we're talking about with these very early stage drugs. So there's a lot of challenges ahead for us. And so I want to just spend the next, maybe I'm running long already, I apologize, I'm going to blame the technical issues, but I'm going to just spend a couple more minutes running through the a few of the things that we're working on here in conjunction with our friends in the Atlanta Regional Commission, the AAA's, state agencies. There is an immediate need to meet those challenges that I outlined for the current needs of our patients and families, but also in anticipation of the ability to deliver more effective care. And so these are some state numbers. So as I mentioned, in up to 2/3 of patients who have dementing illnesses, they never get a specific diagnosis. They're told by their physicians, even their neurologists, that you have dementia, and it doesn't go beyond that. And that is inadequate when we're talking about different diseases with different pathologies that will have different treatments. And in many cases, the diagnosis is delayed until people are often in moderate or severe stages of disease. And that delay is also seen with a great disparity in different racial and ethnic groups, so that our African-American patients and families may have their diagnosis delayed by several years longer than their white counterparts. Statewide, there is an extreme limited access to the diagnostic expertise that we need. There is inadequate support for individuals who are living in the community to support aging in place. And the costs, Medicaid associated costs and Medicare associated costs, are massive. The difference in the amount of the cost associated with caring for a dementia patient versus a non-demented patient in nursing homes is huge. The unnecessary hospitalization rate among dementia patients is extremely high. So these are all enormous challenges. And to do this, I like to tell my friends from Massachusetts and California that in fiscal year 2018, our incredibly progressive state legislature had the foresight to pass, and Governor Deal had the wisdom to sign the Georgia Alzheimer's Project. And the goal of this project and the funding was to support primary care education, to promote early diagnosis and detection of cognitive impairments, to link resources to our patients and families with community-based resources for support, and to disseminate throughout the state a network of experts and expertise that could perform diagnostics and care planning, but also knowledge and expertise to link to agencies and groups and organizations that can provide support, and then help coordinate with the primary care provider. And you see just a few of the partners that we had in the state Alzheimer's Association. We are managed through the Department of Human Services and under Aging Services. They've been wonderful to work with. And the ADRC, the Aging and Disability Resource Connection, the Atlanta Regional Commission, the area agencies on aging have all played a pivotal role in helping us to develop this. So the Georgia Memory Net is what we call this initiative. It's statewide, and you see the locations. We initially established the regional memory assessment clinics in partnership with other academic institutions in the state, MCG, Morehouse, and Mercer. And currently, the other memory assessment clinics are located in the STARS, which is up in Augusta, in Atlanta, down at Grady, in Albany, Columbus, and in Macon. And there are several components to this, and I'm not going to go through the Georgia Memory Net design or components in great detail. But the whole purpose of the Georgia Memory Net is to achieve the goals and overcome the barriers that I alluded to earlier. The requirement for earlier recognition, not just for the treatment ramifications, but also to provide support and education to avoid those disastrous situations where somebody who is having problems is swindled by some ne'er-do-well out of their life savings, or has difficulties related to driving or some horrible accident or other mishaps that can be avoided by earlier recognition and problems and diagnosis. And then address all of those important non-drug, non-extra medical needs that the patients and families have, and to provide ongoing support and education to help both our patients and our families. So this is how I think that we're going to get to this cure for Alzheimer's disease. And I think if through implementation of wonderful partnerships that we've had around the state, we will work together to make sure that the cure for Alzheimer's disease is delivered more effectively in Georgia, perhaps than in many other states and other places around the country and the world. So thank you very much, and I'm sorry for running long.
Dr. Lal, thank you so much. I've heard your presentations many times in different settings, and I'm always amazed how you can put so much information into such a short period of time. It's very informative. Thank you. Do have just a few questions with about 7 or 8 minutes to between sessions. The dye test you mentioned, is the dye test only to determine and diagnose Alzheimer's disease, or is it beneficial for other forms of dementia?
Yeah, that's an excellent question. Right now, it's ironic that when I see patients and families, they are most terrified of hearing Alzheimer's disease. But in reality, we have come the farthest in developing diagnostic tests and therapeutics for Alzheimer's disease. So right now, those the PET scans, the amyloid and tau PET scans that I referred to, there are several amyloid PET scans that are FDA approved for clinical use. We don't use them clinically primarily for the reason that nobody pays for it, and so people have to fork over $5,000 or $6,000 out of pocket if they want to have one of these scans. Whereas we can do the spinal fluid testing, and those are covered by insurance. The tau scans, I think the first one may have just gotten approval. I haven't really been paying too much attention to that. The tau scans become relevant not just for Alzheimer's disease, but in a different disease, something called frontotemporal dementia, or diseases called, there's another disease called progressive supranuclear palsy, and a condition called cortical basal degeneration. These are diseases that are associated with abnormal tau proteins in a different way than Alzheimer's disease is. We're still learning about whether or not these tau tracers are relevant for evaluating and accurately diagnosing people who have frontotemporal dementias and other diseases associated with tangle pathology without the amyloid pathology. But that's a great question.
Great, thank you. An additional question, is there a direct correlation between depression and dementia?
There are very strong correlations between depression and dementia. This is, and I think the person who asked that question recognized that the correlation is not causation. But when you look at large data sets, including the National Alzheimer's Coordinating Center data set, which one of my colleagues did here a couple of years ago, there's a very strong linkage associated with depression and use of antidepressants. And so there is evidence that coexisting depression may increase your risk of developing Alzheimer's disease. It's certainly associated with higher risk of Alzheimer's disease. Whether it was directly causative or not is unclear. And there's some evidence that antidepressant medications may actually reduce overall risk. So there is a strong relationship with depression and Alzheimer's disease. We just don't understand all of the links yet. One other thing that I'll mention, just because I find it really kind of hopeful, one of my colleagues who works on depression, she's a psychiatrist, Elisa Wingo, has also examined the linkage between a measure of what she calls purpose in life. So you can actually use instruments to quantify how strong an individual's sense of purpose in life is. And it turns out that a strong sense of purpose in life is very protective against Alzheimer's and other dementias. And when we looked in the brains of a large cohort of individuals in whom this data was available, and the scores on the sort of higher scores on purpose in life actually were associated with significant impact on resilience against Alzheimer's disease. So, so depression, doing those things that continue to keep you active and give you a sense of strong purpose are really important.
And so, since we're facing our own pandemic with isolation and loneliness, there could be some challenges there in terms of everything you just mentioned.
I'd be willing to bet, Sue, that you have seen the same thing that we have seen in our patient population. It has been an awful, awful, awful time for our patients.
Absolutely. And we're trying to put some programs in place with the Atlanta Regional Commission to directly hope to help people with the isolation factor. So, and I think we are running really close. I'm going to squeeze one more question in because they're coming my way. Is there anything that a person can do to delay or prevent the onset? Many people say, is it vitamin B? Is it the B group? Is it exercise? Is it no sugar? Would you have any?
I love that question. So for anybody who's been in talks with me before, if this is a stale joke, I apologize. So I always tell people there are a couple of things that you can do if you really, really, really don't want to get Alzheimer's disease. One of the things that you can do is to be highly selective in your choice of parents. And then the other thing that you can do is to pull a James Dean and live fast, die young, and leave a good-looking corpse. Those things will almost surely protect you. However, there are other things that you can do. We have lots of data from longitudinal studies, population-based studies, and they reinforce what we all kind of know from common sense, and that is lifestyle factors have a big impact on risk of Alzheimer's and other dementing diseases. In fact, there was a really interesting study from Great Britain not long ago that suggested that with all appropriate modifications in lifestyle factors, that up to 40% of dementing diseases was preventable. And so it is a no small factor. So in terms of diet, we're quite consistent across the medical profession. What we commonly think of as a heart-healthy diet, a Mediterranean diet, richer in fresh vegetables and nuts and whole grains and fruits and less highly processed sugars and fats. Heart-healthy diets tend to be brain healthy and tend to lower risk of Alzheimer's disease and other dementias. Aerobic exercise is becoming increasingly recognized as a critical factor in healthy brain aging. There is some evidence that people who have done a lot of lifelong sustained aerobic fitness actually have lower biological age than those who do not. And then something we've known for a long time, that educational attainment is a surrogate. So lower education disposes you to higher risk of developing dementing illnesses. And we think that's because education is a surrogate for what you wind up doing during the course of your life in terms of occupation. So those who are being more active and using their mental faculties, that appears to be a beneficial thing. So I always warn teachers in particular, because you guys start teaching when you're in your early and middle 20s, and by the time you're in your early and middle 50s, you've got 30 years in and an excellent pension program. That wasn't so bad when life expectancy was 60 or 65, and now you got to think about what the heck you're going to do for the next 30 years of your life. So if you plan on retiring, think about what it is you're going to do after you retire to continue to keep your brain active. So those lifestyle things in early and middle life can be very protective against dementing illnesses in late life, and it's never too late to start.
Thank you so much. So Dr. Lau, we're going to close now, but I'd like to thank you again, not only for your presentation today, but for your relationship with the state of Georgia and the Atlanta Regional Commission. We're extremely motivated and committed to improve the lives of seniors and support caregivers who are involved with this lived experience. So thank you again so much. Over to my co-presenter, Kara, for introduction of the next speakers.
Oh, yeah. Thank you. Thanks, Sue. So we have an incredible panel of speakers, and I don't want to take too long. My brief introductions for each of them is doing them no justice whatsoever and all the great work that they've done. But quickly, I will introduce all three, and then we'll let each of them speak for a quick moment. Bonnie Roach is a technology project manager for the state of Georgia, but admits her most challenging role is caring for her mother, who was diagnosed with Lewy body dementia in 2015. Dr. Kalisha Bonds is a postdoctoral fellow at Emory University with a focus on caregiving experiences of the African American community living with dementia and their family caregivers. And Kim McCrae is a consultant, speaker, educator, and advocate with expertise in caregiving, culture change, and person-centered practices in care. We're going to kick it off with Bonnie telling us about her caregiver journey. And Bonnie, I'll turn it over to you.
Bonnie, we can't hear you. If you will unmute yourself.
Unmuting is good, isn't it?
You're good. You're great.
Okay, I'm going to go to full screen. Okay. And I need to show my screen. Okay. I think we're good. So I'm Bonnie Manz Roach, and I am elated to be here on this panel today and telling my journey. I am not a caregiver by profession by any means. I am a caregiver by love. So we just do the best that we can. So I'm going to just talk just a little bit. I know I need to go fast on some of the things that I noticed with my mom. People ask me, when did you know that she had dementia? I found myself going all the way back to even before I was born and my mom's history, because this is what she talked about when she developed the dementia. The fact that at age between 8 and 10, she was responsible for her 5 siblings when my grandfather left the household. I realized that was traumatic. My mother lost a child at childbirth, and that was traumatic. When she stopped working in 1996 because of health issues, she suffered isolation because she did not have the job any longer. So I realized that was traumatic and isolation. And then in 98, she moved back to take care of her own mother. And that's when we really started to see changes in her personality. She was angry. She complained all the time about everything, with paranoia and obsessive thoughts. Just a whole personality change. That's a picture of her and me. And so now she's having all these behavior changes. And so the diagnosis, the first diagnosis, we were told that she had mild cognitive impairment, normal for her age. So we left, we went home, and my mother was still angry, and it got worse. I tried to figure out what was going on. I thought maybe it was medication, wasn't working right together. Maybe she was grieving her mother after she passed. Maybe my mom just hated me. I actually went through that phase. And then finally, someone directed me to the Emory Integrated Memory Care Center in 2015, and we were told that my mom had Lewy body dementia. I had no idea what it was, had never heard of it. They offered the medication. I declined it at the time because I did not like how she was acting, but I didn't want to medicate her. But I realized I wasn't really in denial. I just didn't understand. So after we left and it continued, I did eventually call back and ask for the medication. Now, one thing I want to mention just for, I guess, anyone else in this situation is because my mom was becoming very difficult and she was angry, I would write these things down in a journal before I would take her to the doctor, because I couldn't talk about her in front of in front of her. So I would send information to the doctor, and a couple of years later, I went back and read everything that I wrote, and it was things like, I would like a recommendation of a type of assessment or someone who can talk to her to make sure that she can deal with her reality until we can understand her condition. I just wrote a lot of things like that, and I realized I wondered why no one told me earlier that your mom has dementia. I mean, it was basically all written out. So now we had a diagnosis, and I moved my mom to Atlanta to be closer to me, and that was 5 years ago. And we experienced a lot of care challenges over the last 5 years. When I moved her here, she could take care of most of her ADLs, but over the 5 years, it progressed to a point where she needed 24-hour care. So during those 5 years, a lot of the care was finding caregivers that had experience and skills in dealing with dementia. We dealt with a lot of 2 a.m., 3 a.m. phone calls, trying to intervene and calm her down. The funding, the cost of, as her disease progressed, my bank account decreased because the cost increased. And I had CCSP, it was a huge help. But there were many challenges like that. I worked from her home. I was never home, just spending time with her and helping to take care of her 24-hour care. So eventually, I had to find another solution. Oops, sorry. So, and also I just want to quickly mention that in trying to give her that quality of care, I tried to always stay in front of the dementia by getting different devices like trackers, hot pots, the cameras, things like that helped tremendously. So I had to find another solution, and I moved my mom to a memory care. So finally, I'm thinking this will help. And for a few weeks it did. She adjusted well. She walked around the place. These are some pictures. She ate with people. She sat with people, but she had dementia. That's why I took her there. But within a few weeks, the facility sent her out for a psychiatric assessment because of her dementia behaviors. So my mom and I spent 3 nights in a psychiatric unit of a hospital waiting for her to get an assessment. So she was sent to a psychiatric hospital for an assessment, and she was told she couldn't come back to the memory care until she had the assessment. I did not know what the assessment entailed at the time. I'm sorry, I wanted to just go back to this screen. So I didn't know what the assessment entailed at the time, but I would call every day because for the first time, I could not get to my mom. I could not be with her. So every day I called, and I was given names like Risperidol, Haldol, Seroquel. I know those names now very well. And as I visited my mom for the limited visitation, she went from being able to walk and talk and eat till about the 5th day. She could not talk to me. She could not eat on her own. She could not walk. And so I wrote a letter to give to this facility to say, please, on my mom's behalf, please stop giving her these things because she can't do anything. And before I could do that, I got a phone call that morning and said, we could not wake your mom this morning. We're taking her to the hospital. She was taken to the ER, and my mom went into cardiac arrest, and she ended up on life support as a result of that. And we spent about 3 months in the hospital. She did come off of life support, but the thing that I always say about that experience is that I took my mom to the memory care because she had dementia. They sent her out of the memory care because she had dementia. And I truly believe that that decision should never have been made. And so finally, 3 months later in the hospital, she's released from the hospital. And this is another story I want to just share with other caregivers because just a lot of things just happened. So she was released, and the ambulance took her to a nursing home that would take her with Lewy body dementia. And we sat And I do want to go to my other slide because this is a picture of her the day we left to get on the ambulance. We had lunch. When she arrived at the nursing home, she was in distress. She couldn't speak. She was sent back to the ER, and my mom ended up on life support again. I felt like I was in a horror movie and we could not get out of the hospital. So I always share that with people because after that, anytime my mom goes on an ambulance ride, I'm right there making sure she's handled in a certain way because dementia patients are very fragile, I learned. So I noticed some things in terms of what can memory care and nursing facilities do to help and to make this easier based on my experience with the memory care and my mom being in the nursing home. I always say, in making decisions, remember that we care for the person. We're fighting the disease. And I think that will make a huge difference in how decisions are being made. And I think my mother never would have been sent out of the facility that caused her harm. Educate to understand. I want to dispel the stigma that a person is bad, especially if they have Lewy body dementia, because I've been told in those environments that, you know, my mom is mean or she's bad or she's all of these things. So I think education would help with that, and training. Learn intervention techniques. There are other things that can be done instead of medication. And I always mention Teepa Snow on that. Allow cameras in the facility. And that particular facility did, and it helped me tremendously to have eyes on her and to help them. I ask that facilities be collaborative with families because we're taking care of them. We know signs of things that you don't know. And then there are these post-COVID things. Encouraging essential caregiver visitation is very important for the isolation. And I'm going to go fast. Lessons learned. Lewy body dementia patients are extremely sensitive to first-generation antipsychotics. After my mom had cardiac arrest, I did the research, and it says that. And so from then on, I made sure that she was never given antipsychotics. I won't say any. She's taking some now, but it can be detrimental. I believe that everyone that comes in contact with dementia patients should be trained on intervention techniques. I don't care if it's medical transport, food services, facility maintenance, everyone should understand how to interact with a person with dementia and understand it from their perspective. And family caregivers, I got myself training. It helped tremendously. There are a lot of resources out there that I can't say enough about. And I always say leverage the care visits as opportunity to do basic health checks of the caregiver. When I took my mom to her doctors, I just wish someone would check my blood pressure. So those are some things I just wanted to share. I have so many other stories to share, but I thank you for your time. And these are just some pictures of my mom and I before and after, and me watching her through the window at a nursing home after COVID. So thank you all for your time.
You're welcome. Thank you.
That was incredible. Thank you. And I'm excited. I'm sure people will have questions because your story is so compelling. We will move now to Dr. Kalisha Bonds. Dr. Bonds, I'll turn it over to you.
Hello?
Hi, we can hear you.
You can hear me?
Yep.
Okay. And you see me too?
We can see you.
Okay, thank you.
I'm not sure who's speaking. That's not me.
No, this is Cassandra Horton. I'm Tawanda Horton's mother. We're here at the personal. She's the owner of Edna Care's personal care home, and I'm sitting in for her, my daughter, listening and to write down notes. And to,
Okay. All
Yes,
right.
ma'am. I think you need to mute right now, and then when you have questions after the panel, we will give you the floor if that's okay.
okay.
Okay, Dr. Bonds, are you set now?
Thank you. My name is Dr. Kalisha Bonds Johnson. I am a postdoctoral fellow in the School of Nursing at Emory University. And actually, I really appreciate Ms. Bonnie's presentation because it was those experiences that led me to pursue my research career. I am a psychiatric mental health nurse practitioner, and so I spent the bulk of my career working as sort of the liaison between nursing and medicine and nutrition and all the other different parts that make up the nursing home and sort of assisted living setup. And so I just was really grateful for her presentation, and I was reminded of why I am doing the research that I'm doing. So again, my presentation is entitled Race, Culture, and Family Caregiving. And okay, here we go. So my research focuses on caregiving specifically within African American communities and families, because research suggests that African Americans have more than double the prevalence of developing dementia. This prevalence is related to higher rates of high blood pressure, stroke, and/or diabetes. But despite the prevalence or increased risk, many African American older adults are often diagnosed later in life, resulting in less resources, less time to care plan. And research has focused more on comparing African Americans to non-Hispanic whites or non-Latinx whites than really on focusing within the culture and the community. But there is a movement recently to look at what we call life course factors. So such things as not just focusing on one's race, but looking at where they live, so their environment, behavioral factors such as how the family makes decisions and how the family functions, and sociocultural values are factors such as cultural values and norms. In thinking along the lines of the life course, I want to focus on two identities found within African American culture. John Henry, who really is a folklore character, and the identity of the superwoman. As the folklore goes, John Henry was a strong African American Black man and a steel worker. He is said to have worked as a steel driving man, tasked with hammering a steel drill into rock to make holes for explosives when building the railroad. According to the legend, John Henry's strength and ability as a steel driver was measured in a race against a steam-powered rock drilling machine. Now to the superwoman, or this idea of the strong Black woman. Over at least the last 10 years, research has focused on African American women and their identities. And so I'll go into that a little bit more next. So the origins of the African American woman, and before I continue, as I'm speaking, I hear myself going between the word we and you. As a researcher, I'm trying to be more objective, and so I say you. But also I identify as an African American Black woman, and so I will say we at times too. So as I was saying, the origins of being a strong Black woman or superwoman was in response to negative stereotypes of African American women. Mammy, one who was cared for by others, was replaced with mother, to care for one's own children. Jezebel, being promiscuous, was replaced with the identity of being a nurturer or a giver. Welfare queen, or the image of seeing a woman with multiple children, was replaced with the idea of being a breadwinner. So the idea of being a strong Black woman or a superwoman in and of itself isn't all bad. And honestly, it's not at times. But to do this day in and day out is too much. So the legend of John Henry, as I mentioned earlier, he was a steel worker, asked to race against the steam-powered machine. He was the winner of the race, but he had a heart attack and he died with his hammer still in his hand. While John Henry is a folk hero, there is some truth to the story and how many African American men may feel. If I'm being honest, most of my research focuses on women. I did a community outreach last year, and a few men came up to me afterwards and expressed their appreciation for my talk, but also their lack of representation. Many African American men are caregivers, though not to the mass majority of women, and their desire is still real for them to be central and important in this caregiving process. So you may be asking yourself, Dr. Barnes-Johnson, why does this information matter? What does it have to do with dementia caregiving? Well, these cultural identities can influence how caregivers feel, respond, or react to their caregiving experiences. There is no one size fits all, and I think Ms. Bonnie's presentation speaks to that. The idea of a memory care clinic assuming that all dementia patients will perform, act, behave a certain way, and when one acts differently, isn't able to handle that is a problem. For the caregivers in the audience, there may be moments where you feel like, I'm doing this for my family. I have to be strong at all times. I don't care what it takes. I can do this on my own. I won't let them see me cry. Never let them see you sweat. I will give and give until I have nothing left to give. Who are these African American caregivers? They're primarily women, which I mentioned earlier. And when African American caregivers are compared to non-Hispanic or non-Latinx white caregivers in research, African American caregivers often report less burden or stress. But I think that's because there's a mismatch in how we're doing our research methods. When we ask someone a question, bubble in a survey, how stressed are you? Very stressed, not that stressed. Then on those reports, African Americans tend to report less stress. But if we take the time to interview caregivers and ask them about their lived experiences, they often share that they are burdened and stressed. There is research focused on how we capture information from research participants, but more work needs to be done. In my own research, I examined both African American persons living with dementia in mild to moderate stages, mainly and their African American caregivers together. This is referred to as the African American dementia dyad. In these dementia dyads, my research has identified that African American adult daughters and daughters-in-law caregivers may be at greater risk for worse quality of life than persons who are cared for by their spouses. And this is why I focus mainly on women more so than men. Taking on the role of the primary caregiver or main caregiver or one of many caregivers can be more than one person can bear. In these moments, it's important to reach out to seek help, but reaching out and seeking help may feel like we are failing at taking care of the person living with dementia. This slide is to encourage the spouse or partner of a caregiver to look for ways to support these dyads. For family members to notice signs of stress and burden, which can be challenging if everyone is assisting with care. For friends and coworkers who know that your friends and coworkers are caregivers, checking in to see how they are doing may be just the support they need, especially given the current pandemic. As a healthcare provider and a researcher, I put a great deal of onus on us. Providers need to understand that there is variability between African American caregivers and their dementia dyads and families. They need to provide education and meet caregivers where they are. I know the healthcare system isn't set up to work like that, but there are ancillary staff and support staff who can assist with supporting caregivers. Lastly, research should focus on understanding the nuances between caregiving situations and not just attribute negative experiences to one's race. We know that race is a social construct. It's not biological. No, there are so many factors that play a part in one's overall health. It's not just because someone is Black or because they're African American. For example, where we live, so our residents, how we communicate.
Sorry, I was muted for a minute or I lost my mic. I'm almost done. Sorry about that. So again, our residents and where we live, how we problem solve and communicate, whether we are discriminated against or perceive that we're discriminated against, and our own cultural beliefs and values make a huge difference. And whether we're receptive and willing to be a part of research. So I want to leave you with this quote from Maya Angelou. If I am not good to myself, how can I expect anyone else to be good to me? Caregiving requires giving of oneself to help someone else. But if the caregiver is empty and running on fumes, there is nothing left to give to the person living with dementia, and even less for oneself. Thank you.
Dr. Bonds, thank you so much for that. It always, when we do forums like this, I sometimes wish they were all day and we could just keep going, because what each of you are saying is just so important, and I really appreciate you and the work that you've done and continue to build on. Our next speaker is Kim McCrae, and I understand there's some technology issues. Is Kim with us? Oh, Kim. Welcome.
Kim, you're self-muted, so if you'll take yourself off mute.
We're living in the moment, you guys, with technology. All right. Okay, let's go. I am Kim McCrae, and I'm so happy to be with you today. All of these presentations have been amazing. Let me introduce myself quickly. Within a 5-year period, my husband, Frank, and I took care of and lost his mother and his father and my father. And when I was 35, I inherited my mom, Barbara, who was 62 and had yet undiagnosed Lewy body dementia and progressive supranuclear palsy. So I became a full-time caregiver when I was 35. I feel the pain that you all are going through. There are a few things that I just, having listened to what everyone said and realizing that, 44% of you are people who are family care partners and people who are living with some type of dementia, as well as providers of different types who are working with us, with family care partners and people who are living with dementia. I think there's some things that are really important for us to think about. Now, Dr. Law walked us through the medical piece, and primarily the medical piece about Alzheimer's. He explained to us that dementia is like an umbrella. If we think of dementia as an umbrella, and then Alzheimer's and the different types of dementias, those are under the umbrella. So under this umbrella, it could be Lewy body dementia or progressive supranuclear palsy or vascular dementia, all those different kinds of things. We have to learn to think about the word dementia as there are things that cause symptoms of dementia. Something that's so confusing is when the word Alzheimer's is used as the same word as dementia. It confuses all of us. It's really important for us to know and understand that dementia and Alzheimer's should not be used interchangeably. It's not correct, and it's confusing when we say Alzheimer's, but we mean all of the other dementias. It makes us all confused. We have to understand that it's really important to try and get at the root of what type of thing is causing the symptoms of dementia. And like Bonnie was saying, part of what we all can do is try and gather the clues and the symptoms, the things that are happening, so that we can share them with doctors and physicians to try and really figure out what it is that's causing this, what it is that's causing these things that we're seeing. And sometimes there are things that can be causing symptoms of dementia that we can sometimes even fix. So Bonnie, your journal that you were doing was just an excellent idea, and none of us need to feel guilty or like we're being sneaky if we do that. In fact, that's something, the more that we can talk openly about dementia without stigma, the better able we all are to change the conversation around all of this. So the best practice is for us to use the word dementia, including Alzheimer's. If we say that and do that, that will really help all of us move forward in the field. The other thing that's really important for us to think about is we all are so much more than just our diagnosis and what's wrong with us. In fact, we are only a patient when we're in the hospital or when we are at the doctor's office. The rest of the time, we're full human beings. People who are living with dementia are not patients every day of their lives. And you caregivers and care partners, you all are not just supporting and doing for and having a burden. We need to all learn to look at ourselves as a care partner team. And when we do that, we need to think about it like this. The person who's living with dementia and the family, the primary family care partner, is at the center. And then draw a circle around it, and the doctor and the other doctors, because there are usually many, they are all a part of the care partner team. And then if we have all the other kinds of support and services, for example, all the wonderful things that are available through the Atlanta Regional Commission that they'll tell you about in a minute. You know, every single piece of our care partner team needs to work together and know the person living with dementia, not just for what is wrong with them or their diagnosis. We need to know who they are as a person. And Bonnie did such a beautiful job of that when she was talking about who her mother was and what her life was about. We also have to use that kind of thinking when we are trying to figure out how to support people who are living with dementia and help them live their best quality of life. And that's what we need to do, is really get to know the people and not think of them like everything's wrong. We need to think about these are people who are living with a changing brain. People with dementia are living with a changing brain, and they want to know how to live well with dementia. That's key. We all can work together to help people live well with dementia. And ways that we can do that by having conversations with each other and talking to each other. And as Dr. Law said, finding out about what's important to somebody and what is their sense of purpose, what gives them joy and pleasure. All of this that I'm talking about, this is instead of having a medical model focus where we're just focused on what's wrong and just the medical issues, we're trying to look at the whole person and what's important to them. What are their goals? What brings them joy? And what brings them purpose? So this is the person-centered model and person-centered thinking. And we can all work together to implement that. I've included, and they will upload for you, some definitions of person-centered dementia care and support, as well as some videos that there are 9 or 10 videos, really short, that you can watch that will give you a lot more information about how to help people have a good quality of life and live well with dementia. Thank you. Sue, I can't hear you.
Always forget to unmute. Thank you. Thanks, Kim. Thank you to all of the speakers, Bonnie, Dr. Bonds and Kim, all giving different perspectives, different levels of focus, along with Dr. La's presentation. This has been, I agree with Kim, a tremendous panel of speakers, and I think we've learned a whole lot. There obviously is so much more to learn and so much. I don't see any questions showing up in the chat feature, but I do have a couple of questions here that we often ask each other at Atlanta Regional Commission, and many people who call in, either as a caregiver or with lived experience, ask. So if it's okay, I'll ask all panelists. The question about caregiving, and Kim, you gave an amazing example of how at such a young age you became a caregiver of multiple family members. Do any of you have any tips for maintaining a sense of self and identity outside of the caregiving role, knowing that it could be all-consuming at that point in time? Perhaps share what helped you, what helped ease the burden for you, any tips for other people with this experience?
I see Bonnie thinking. She's got good things in her mind.
Might need to unmute, Bonnie, if you're talking. Yeah.
Okay, am I unmuted now?
Yes.
Yeah, I would say to that, I had one aunt that helped me tremendously. I don't know what I would have done without her. Use any resources. And I was just like, Clecia, like you were saying, I tried to do it all by myself for a long time. And now I will accept any help that anyone offers me. So I would definitely advise anyone in that situation to do the best you can. People would say, take time for yourself. And I would still say there is no time, but you do have to try and use any help that is offered to you.
One thing I think we all would agree on is to try and find support groups of some kind, and don't be afraid of that. Right? I mean, trying to find people that have a shared experience, like you were talking about, Dr. Bonds, finding people that you can talk to about it who have also gone through it, and not be afraid to talk about it. Don't be afraid of the stigma.
And I guess I would just add, you know, whatever it was that made you happy before, like, I'm not a big sharer personally. I'm not a caregiver at this point. My grandmother is aging, but she's doing okay. But I love gospel music. And so just play that when I'm not having a great day or when things aren't going well. I also became a new puppy parent, which is helping also with mental health. So just figuring out what it is that I think gave you joy before caregiving and trying to find creative ways to incorporate that in the caregiving process.
And Dr. Barnes, perhaps a pet helps. Having a lovely pet, I think that's great. I see the peeking face. I think it's a dog. but that could be helpful as well. I mean, they bring a lot of joy every day as you're kind of mustering through some of these challenges. I wanted to share with you, the questions are really about caregiving. And one of the questions that I had here was what type of caregiving supports are available, and if we're uncomfortable having someone come into the home as a result of COVID. So this has really changed the lives for both caregivers and people with lived experience. People with lived experience might be facing more isolation and might have to be more independent than perhaps they're able to be, and or the caregivers are also isolating. I mean, when we couldn't leave the house, you know, the days get long and the walls seem to close in on us, and in addition to these challenges of caring for a loved one. And so I wanted to share with everyone that the Atlanta Regional Commission did receive some funds through COVID, through both the CARES Act and the Families First Act. In the Families First Act, which was the first launch of money, it was primarily available to provide nutrition support. So we got really busy with meals, and that could be very helpful for people as well. But in the next round of funds through the CARES Act, we received a lot of funds. We were trying to determine what was the most useful thing. We've developed a couple of programs that we think will be very helpful. One of those is a telephone reassurance model where we can help to provide support to an individual who's isolated or more isolated than before. And then we have some caregiver support programs. One is what we're calling the consumer directed program, where we could support caregivers who perhaps lives have changed as the circumstances change. And we will be able to provide a lot of support for some self-directed services. So that might be in this situation, a person who would have a small budget that's an allowance with this program and could purchase some respite support. And that respite support doesn't have to be a healthcare provider or one of the community-based support providers. It could be a neighbor who's willing to help, but could benefit from, you know, you always feel much better when you can compensate someone than when you feel you're pulling on the goodwill of neighbors and even family members. So that could be very helpful. We have at ARC a care consultation program where individuals can call, and the caregiver is essentially the caregiver is the most important person in that role. And so because very often, and I think I heard Bonnie, you said you journaled sometimes to pass information because you didn't want to express that in front of your mother. And we're very cognizant of that. And so when you can have a caregiver support and it's telephonic and it works within your lifestyle, and it could happen at 9 o'clock in the evening or in your lunch break at work, where you feel you can be in a separate space to have the conversations that you would be very uncomfortable sharing in front of a family member. So that's another service that we have. And then Cheryl, if we have the big slide, the last slide, I believe, will direct everyone in the audience. And I think we've got about 175 people. That's fantastic. But we want to let you know what other opportunities you have. And really the best way to approach us is through the ARC-Empowerline, which is where we house the ADRC, the Aging and Disability Resource Connection. And you can call in and receive counseling, an initial assessment of need, or you might have a very clear idea of what you're looking for in terms of approaching some community services. You can call 404-463-3333. And we have a lot of experienced counselors who can talk about your situation in a very person-centered way and offer you resources and link you to programs and services and supports. So that's really a very important thing, 404-463-3333. If you go to, and I'm not seeing the slide, Cheryl, but I'll just keep talking, empowerline.org, which is our website, you will see descriptions of services, and we will soon, not yet, but very soon be launching a kind of self-directed database, a resource database, where you can search for some of these options, adult day health services or some in-home services. We are launching that very soon, so that we feel that helps, because when you're caregiving, how do you separate from that role of caregiving to take a minute to research and understand what other services are out there? And we're developing new services all the time. We also have the Older Americans Act services, where we can bring some nutrition services into the home, personal care, homemaker, and respite, very importantly in this topic, respite. And then Bonnie, you mentioned the community care services program. We serve as the intake system for the elderly and disabled waiver, which is where the community care program and the source program originate from. And so we welcome those calls. All of those calls can come through 404-463-3333. So go to the website. I know Doug Hooker, our executive director, and our director, Becky Kurtz, the AAA, the Area Agency on Aging director, would want to say thank you all so much for participating. They may or may not be on the line today, but we will be sharing with them how successful this has been. And I know that they would be thrilled to see so many people involved. And Cheryl just popped up a reminder for this ongoing series of forums that we have. And if you can join us next week for the forum, What We Know or Don't Know About the Economic Impact of COVID-19, that could be very interesting to some of you. And we ask you to go onto our website, atlantaregional.org/webinars, and share it with colleagues and friends and join us, because there's a lot of overlap here in terms of how we can continue to work to support older adults with a special focus in dementia. And with that, I think we're right on time to close. Thank you again to all of the speakers and all of the folks in the background who've made this possible, this new environment we're working in. Cheryl, Kate, thank you so much, and hope to see you at the next forum. And thank you very much, all of you who participated today, all 175 plus of you, thank you, and goodbye.